So we're recording now, but I'm going to let Tanya and Dr. Usher introduce yourself if you don't mind, and just let you get started on this presentation.
Excellent. Thanks. Tanya, do you want to start?
Yeah, I will. My name is Tanya, and I've been working with EASA now for about 13, 14 years. And prior to that, I worked with birth to 3. I was helping with placements for babies into speech therapy, occupational therapy, and physical therapy. I was the bilingual therapist and continued being the bilingual therapist for birth to 18 in a home health care program for children with complex needs. I followed that with doing some hospital work, working in pediatrics and, well, all ages at the hospital. So I am excited to be here. And for me, this is really neat work because I'm able to take various aspects of my career and they're coming together. Thanks.
Thank you, Tanya.
And I'm Craig Usher. I am a professor of child and adolescent psychiatry at Oregon Health and Science University. And my background, I first did medical school in Washington, DC, did 5 years of my postgraduate training up in Boston. And then I did a year of social emotional cognition research and outpatient practice in Chicago before moving to Portland. And I worked with EASA. That was one of my first jobs back. I worked in a program that was just starting in Washington County, and I'm always proud to say that we started with 4 participants, and by the time I left, we had a roster of about 65 people in 2012. So really got to enjoy the growing pains of starting a coordinated specialty care program for young people with psychosis. And as part of that, germane to the topic today, we had a number of young people who, even without knowing the research, just found a group of people for whom diagnostic silos certainly didn't work, and with autism spectrum disorders and other sort of mild social emotional cognition difficulties that we were monitoring closely. So anyway, this is near and dear to my heart. And so if it's okay, Missy, I'll just get started with our slides. Today we're going to be talking about autism and psychosis and different permutations. So I'm going to screen share. I'm not as adept at using Zoom. We are stuck with WebEx at our university, and hopefully we'll make this work.
Thank you. It looks good so far.
Okay, great. You're not seeing presenter view, but you should be seeing the slide program itself. Okay,
correct.
Excellent.
Weird.
Perfect. So please stop me at any point. We'll hopefully, leave time for questions, but just in case, if you've got a question, please feel free to interrupt me and say Craig and stop. So I don't have any biomedical, financial, or ethical conflicts of interest. My thoughts are really guided by Alan Francis of Duke University. He wrote this quote a few years ago in the American Journal of Psychiatry that drugs don't cure schizophrenia, and they usually don't work for a person with a mental disorder if that person doesn't have a place to live and an adequate support system. And we place a really bad bet for ourselves and for the folks that we work with if we expect, big biological breakthroughs and tamely accept a role as pill prescriber, as psychiatrists, or as pill pushers, as clinicians, or even CBT pushers. What we are is really, we ethically looking to support people as best as possible and to bring people into our programs for whom we can really offer help and make sure that we're partnering with other programs. And we're going to talk about breaking down some of the silos at the end of today's talk. Our learning objectives: by the end of the session, you should be able to recite the DSM-5 criteria for schizophrenia and autism. You hopefully will be able to embrace Karl Popper, psychiatrist and philosopher's axiom: science is the art of oversimplifying nature, particularly as this applies to the autism spectrum psychosis divide. You should be able to cite at least one historical example where the term autism was considered a hallmark of schizophrenia. You should be able to describe how schizophrenia and autism share at least 3 clinical and 3 neurobiological features. And finally, you should be familiar with using a longitudinal interview approach to distinguishing autism and psychosis, and then autism with psychosis, and then psychosis without autism, but maybe with some autistic features later onset in teens. And then Tanya will share with you an understanding of an occupational therapy framework for working with youth who are duly diagnosed with autism and psychosis. So first, some DSM-5 definitions. So remember, psychosis is a generic term that essentially means or entails a break from commonly shared reality. Its hallmark symptoms, you have to have at least 3 of the following: delusions, hallucinations, and disorganized speech, DHS. And then you can also have disorganized behavior and negative symptoms. And so I use to teach medical students, I use the acronym DHS-BENS, find that it helps. Remember, if you have symptoms for 3 days to a month, that's called a brief psychotic disorder. 1 month to 6 months, that's called schizophreniform disorder. And greater than 6 months, we call that schizophrenia. You can, of course, exit this diagnosis. Delusions are often persecutory in nature. They might involve an individual believing that they're being followed, spied on, cheated on, poisoned. It could, involve Capgras syndrome, where you believe that your relatives and friends, those close to you, have been replaced by imposters, or that strangers are actually being occupied by the person of another, of a loved one. And we call that Fragoli syndrome. A grandiose delusion is believing that someone is special or a chosen one, perhaps that they are God or God-like. Hallucinations are a sensory experience in which a person can see, hear, smell, taste, or something that is not there, where there's not an external stimulus. And we can bookmark this because this is maybe a shared feature with some aspects of autism. An illusion is a pattern like a trailing light. It emerges from a sensory phenomenon that we could all see, but then it morphs into something else. So it's not a spontaneous hallucination, but it's something. It could also be an auditory illusion. So you could have something that sounds, similar to 2 people, but it holds a special resonance and a special meaning for another person. An auditory verbal hallucination is AVH, and that's usually a voice or voices commenting. And then nonverbal auditory hallucinations are very common in early psychosis. And that usually involves buzzing, clicking, a knocking, drilling, or whooshing sound, which leads a lot of people to believe that they have been infected or received an implant through dental work, because the drilling or buzzing sound in their head is similar to that which you get during dental work. So you'll notice a lot of people that we work with, at least in my experience, are afraid of going to the dentist for precisely this reason. Remember, hallucinations, they increase psychiatric risk, but they are not necessarily tantamount to having psychosis. So auditory hallucinations can be associated with all sorts of things, particularly trauma in very young people. If one has isolated auditory hallucinations, they are at great risk for developing a psychiatric illness as they move forward, or for still suffering psychiatric disturbance, but they are not necessarily at increased risk for psychosis. Something that would increase the risk of psychosis is being pretty distressed by your hallucinations. And these are some qualities that would lead people to be distressed: having a negative sense of self-worth, an experience of having been bullied or traumatized, a low sense of self-efficacy, and having less family support. And remember, hallucinations are pretty common. About 13% of children aged 9 to 12 have hallucinations. Still 12% for ages 13 to 18. And into adulthood, it's more like 6% for individuals 18 to 60. And after 60, it's about 4.5% of individuals. But if they're associated, if those hallucinations are associated with things like disorganized speech, dysregulated behavior, where people might be laughing, crying, smiling, featuring odd affects that don't necessarily match what the topic at hand is, when they socially withdraw, when they start confronting others or making accusations that seem kind of out of the blue, that is that's the behavior dysregulation associated with schizophrenia. And then finally, negative or cognitive symptoms are things like motor activity that's extremely slowed or discoordinated, difficulties initiating, sustaining, or shifting attention, difficulty solving problems, poor executive function. So turning from that DHS bends, those qualities of schizophrenia, autism is defined by really two main criteria. So one is social. So difficulties in social emotional reciprocity, so having an abnormal approach to conversation, not being able to engage in conversational back and forth, and a reduced capacity for sharing one's interests, their emotions, for sharing affect in that, kind of mirroring back and forth someone. All of those are associated with autism. And then there's deficits in nonverbal communication. And you see this earliest in children, a lack of proto-declarative pointing. So most children, by the time they're 1 year old, they won't simply, if I say, Tanya, look at this slide, I will need Tanya to first look back at me, and then for her to point to the thing, and I will then show her together that we're looking at the same thing. And that's a really, that declarative pointing, I'm getting your eye contact and I want to push you over there. That can be one of the earliest signs of autism. An overall abnormal eye contact, maintenance, lacking eye contact completely, lacking facial expressions. Those things can be associated with that nonverbal communication deficit criteria. And then part B of the autism diagnosis is restricted repetitive patterns of behavior, interest, or activity. So again, this has to be in multiple contexts. This can't just be in one, say, in one area where if a toddler is in daycare and they're extremely anxious, they might demonstrate some of these qualities, or around a care provider or others that they find frightening. But again, this is in multiple contexts, even in a secure attachment setting. So in this, the first quality that we think about are stereotypies. So that's flapping, clapping, spinning, lining your toys up in a certain pattern. Those really restricted patterns of kind of motor behavior. And stereotypies are often self-soothing techniques. And so there's a quality of this which is normal. We all do things that soothe us. For me, what soothes me is I say the term "in any event," or I might push my glasses up. I mean, we all have these qualities. These are extremes of things that, think about when you're, if you play sports, things that you do to kind of get yourself ready, and you do them repetitively. These are heightened versions of those re-regulation strategies. There's also an insistence on sameness, routines, rituals, doing things over and over the same way, and enjoying the same foods over and over. Restricted, fixated interest is another criteria. And this is usually being really into one hobby. I'm going to give you an example later, but I used to work with a young man who could tell me about all of the high-rise buildings in Portland. He could tell me what kind of elevator they used, the year it was built, and gave me a real tour of our Otis elevators and the mechanism of action at Dornbecker Children's Hospital. It was really impressive. But this was to the exclusion of us being able to talk about just about anything else. It was still a fun topic. Also, it can be an interest only in the parts of objects. And again, we'll talk a little bit more about this. And finally, there can be a hypo or hyper reactivity to sensory stimuli. So the most common one, and this bothers most of us, which would be tags on your shirt, but really only being able to wear certain clothes. Misophonia, that's difficulty with sounds made by other human beings. So their breathing or the chewing sound that other people have might be a huge trigger for some folks, just period, but particularly with young people with autism. And there can also be an indifference to pain. So sometimes kids will first come to our attention because they are bleeding. They have, a massive bruise, and the child's not noticing. So this makes a nice acronym that I share with medical students. It's RN-SIRS. So maybe this is like male nurses, I don't know, but RN-SIRS. So the first two criterion are reciprocity in social communication difficulties, criterion A, reciprocity challenges, and nonverbal communication difficulties. So that's the RN. And then for restricted repetitive patterns of behavior, that's stereotypies, insistence on sameness or inflexible adherence to routines, restricted interests, and finally sensory issues. So it makes for a nice enough acronym if you need those. When you record an autism spectrum disorder, particularly after the DSM-5, it's considered a requirement to note what level of support someone needs. And so I routinely have to get out my DSM-5, my pocket DSM-5. I don't know where it is, but when I work, whenever I make the diagnosis or I'm working with folks, I get out my list. Some of the features are listed here, but essentially you have 3 levels of ASD. So requiring support, requiring substantial support, and requiring very substantial support. And so I invite you just to read those in the DSM. You may have to pull them up online. What I also ask of my trainees, now that they've eliminated the diagnosis of Asperger's disorder from the DSM-5, I really ask that my residents and my fellows who I work with, that they list out in a sentence, what are the chief deficits? And maybe, of course, what are the strengths, which we always want to begin with, but what are the deficits associated with with this person's version of an autism spectrum disorder? I actually think that that's probably one of the most, beneficial things that we can do when we list schizophrenia. The DSM-5 eliminated a lot of the adjectives to describe schizophrenia because they found that scientifically there wasn't a difference between disorganized type and, say, paranoid type. But it really does help to list, if you're going to list a diagnosis, to really try to capture that person. What are the person's central deficits? So this is an example. So a young man has autism spectrum level disorder level 1, featuring monotone speech, poor eye contact, and occasional hand wringing, which is not hugely disruptive to his life. He has an IEP for speech, working on pragmatic language support. He has great social interests, many friends who just know I'm quirky, and he's academically doing well. So that person with ASDs is completely different than an individual who has an IQ of 55, is largely nonverbal except for letting caregivers know their most basic needs, but they share this diagnostic label but the support that they require is worlds different. So it's really helpful to list this. So if you've ever been confused about autism versus schizophrenia, you're in good company, and there's good reason that you might be confused. historically, there's been very little distinction. So this really stems from, I think, one of the heroes of psychiatry named Eugene Bleuler. He was a Swiss psychiatrist. And in the late 19th century, he saw his sister's treatment at this Berkholzli asylum in Zurich, Switzerland. And he saw that he had felt that the director of the asylum that she was in and of other asylums, that they were most interested in treating the residents as though they were lab rats, that they were there for science, but they weren't really there for care. And his sister was being treated for schizophrenia, and he felt that he really wanted to change that. So he developed his own, he was the director of his own psychiatric asylum. He was really interested in studying psychoanalysis and a really humanistic approach to the human experience, and also considering biology. But he eschewed the extremes on both sides. He said, if you just follow a biological position, you forget about the humanity of individuals. And if you just focus on the humanity, you get so wed to your ideas. He left psychoanalysis, I think, around 1912. He wrote to Freud, your all or nothing approach is, in my opinion, necessary for religious communities and useful for political parties, but for science, I consider it harmful. And so what he wanted to do was really characterize the people that he was working with. And so he took an open view, and he developed a number of terms, including the term schizophrenia. He said, not everyone that I'm treating has this early onset dementia or dementia praecox. And in fact, many of the folks that I work with, they end up doing very well. He said, of the symptoms that I'm seeing clustered, there are four that seem most prominent in the young people that I'm working with. And these are Bleuler's 4 A's. So he said, I see a loosening of associations with people tying ideas that are disparate one after the other. I see a blunting of affect and diminished reactivity of people's facial expressions. I see people having a lot of difficulty making decisions. Excuse me. They're filled with conflicting emotions. They can't organize their thoughts and feelings. And then finally, he talked about autism. He said autism, and he really coined the term. Although he was talking about schizophrenia, he was really the first to use this term. He said autism, there's a sort of self-absorption, a withdrawal from external reality with a preoccupation with inner life. And autism comes from the Greek word auto. It just means autoism or selfism. So that's really, that at its most basic, that's what autism means, preoccupied with self. Emil Kraepelin was a prominent psychiatrist around the same time. He was from, I want to say from Vienna. He coined the term early onset dementia or dementia praecox. But when he talked about it, he was also really talking about children. And he said, we are, quote, we are dealing with children who have always shown us a quiet, shy, withdrawn nature, engaged in no friendships, and only lived for themselves. And by the way, the etymology of this word is kind of interesting. Dementia, dement means dement, so stop mentating or reduce thinking. And praecox means very early. So he believed in this sort of very early reduction in thinking. And he was probably talking about both people who had what is contemporarily thought of as schizophrenia, and he was talking about youth with autism. And in fact, those two were not distinguished, schizophrenia and autism, until the 1970s, when in the DSM-3, they started separating these out and recognizing there's a window of disruptions of these kinds of symptoms, which occurs right from infancy, toddlerhood, all the way through childhood. And then there's this later onset entity that we now call schizophrenia. But previously there was overlap. If there's historical overlap, there's also overlap in reality and shared biology. People with a family history of schizophrenia have an increased risk of autism spectrum disorders. So there's a threefold increase in a child having autism if they have a parent with schizophrenia, and a 2.6-fold increase, or odds ratio of 2.6 if somebody has a sibling with schizophrenia. They are almost 2.5 times likely to have autism. There is reduced gray matter in the cortex of individuals in a similar pattern with some forms of schizophrenia spectrum disorders and some forms of autism. The third shared biological feature is that individuals with autism spectrum disorders are at increased risk for developing psychosis or schizophrenia spectrum disorders. And this ranges from anywhere from 7% of individuals with ASD develop schizophrenia, all the way up in some groups, this was all the way up to 34%. It probably is, if you average out the studies, it's probably around 10%. So 10% of individuals with ASD develop psychosis. And that's why we're here, because we have this group that's at a really increased risk for developing psychosis, yet we often exclude them based on their diagnosis, or they already have services, or they have a certain service array, or what's worse, we consider whatever is going on for those individuals, and I mean us as a society. I don't mean, we as in EASA and those of you, providing treatment in Kentucky, but someone gets a label and they can't then have anything else. And we see this in our work with youth with schizophrenia or in psychosis. If you have psychosis, well, you couldn't have the flu, or you couldn't have whatever you come in and report in the ER, it gets ignored in favor of this one diagnostic label. And so that's why we're having this talk, to really eschew that siloing. Finally, neurologic soft signs, which is really subtle motor discoordinations, overload, motor overload. You see motor overload as a normal phenomenon in, say, a violinist whose face contorts because they're so they are working so finely on, finger motor coordination that the rest of the motor strip sort of spills over and they throw their whole body into it. Well, a neurologic soft sign might be someone who, as a simple task, holding a pencil, they throw their entire motor system into holding that pencil. And you see children, and adults who do this from time to time. There are also difficulties in social cognition in both autism and schizophrenia. So social cognition, a really quick lesson. I promise I'll be as fast as I can here, but social cognition is how we think about emotions and how do we interact with other human beings. Roughly, being fast and loose with the science here, but there are 3 neural systems of social cognition. There's the social detection system. So you have to be aware that something is social and I ought to pay attention to it. There's making meaning of it. So sort of like, what should I, is this a threat? Is this an invitation? I don't know. And so I have to make sense of it. And the third thing is cognitive regulation, which is sort of that more higher cortex, frontal lobe. Now, how do I then react and reason through what it is that I'm experiencing that's a social phenomenon? So we know to look people in the eye because we have fusiform gyrus. That's that pink line that you see in the temporal lobe. So it extends, fusiform means tapered at both ends. And so this is just one of those folds in the brain that tapers at both ends. Not that clever. This area, though, gets activated when someone looks us in the eye. So what happens when we order Starbucks in the morning, like it or not, when someone attractive hands you your cup of coffee and smiles at you and says, "Good morning, here's your coffee," we get activation of our temporal sulcus, and then that activates through a connection to our nucleus accumbens, and we get a little shot of dopamine. So we get a shot of dopamine because we're anticipating that great cup of coffee. So just the anticipatory dopamine release alone, but also that eye contact with someone, it's really something special. Ami Klin at the Yale Child Study Center did a study where he took a young person who had that quality of restricted interest and within his autism spectrum disorder, and he showed pictures of people's faces and eyes looking back at the child, smiling. And what he found in a young person with autism, he also did this with washing machines and other individuals' interests. What he found is that this young man's fusiform gyrus did not get activated. But when he used his interest, which was Digimon cards, that young man's fusiform gyrus did activate. And what he reasons from this is that when we command young people, we say, look me in the eye, or look that person in the eye, or why aren't you looking, why aren't you making eye contact? Well, because the machinery of knowing that eye contact is an important thing is not working well. And so what you might do to help someone develop more pro-social skills is you might develop it through the person's interest. So if it's Thomas the Tank Engine, you use Thomas the Tank Engine to extend then to human behavior, not human behavior then mapped onto, Thomas the Tank Engine. Like, don't quit watching that show. You need to look people, start being more social. It doesn't work. And this is just a slide that shows that in some individuals with autism spectrum disorders, there are disorganized, inadequately pruned neuron activity or neurons in the individual who had autism in their fusiform gyrus. Another way that you figure out that things are social is you project human qualities onto things. This is a great example. This is a point light walker, and most of us can imagine that this is a person walking from the, the right side of my page to the left. And you can detect a lot of emotions from point light walkers. There are other videos which really get at this quality. Again, this is our temporal lobes. They help us project qualities of social life onto things that aren't even overtly social. We have to make meaning of whatever comes in, and so we do so largely in our through our amygdala, our hypothalamus, and our nucleus accumbens. It helps, these regions help us know whether threat, danger, or invitation is coming. So these are two examples of tests that you can use to examine people's social cognition. This is Simon Baron-Cohen's reading the mind in the eyes test. You can take this on the New York Times website. It's from, I think, about 6 years ago, and you can it's considered a proxy for how readily do you read other people's emotions. This is also another paradigm that you can use called Adolph's faces at the bottom. And of course, there do seem to be some universal emotions where these facial expressions worldwide, no matter who sees them, tends to imbue them with these qualities. People who have a lot of empathy and a lot of social savvy tend to answer in a similar way to most of the population. So they would readily say, well, that's an angry face there at the top, there at the bottom, in the bottom right corner. Oh, that's surprise, the eyes big like that. And of course, it doesn't mean, just because I label something, it doesn't mean I'm correct, but it means that if Missy and Tanya and Robin and several of us got together, we would pretty much agree, like, yeah, I think it's that. Maybe one of us, maybe Megan might say, no, I think that person's sad, not angry. So there can be some deviation. It doesn't mean we're right, but it means that we share a sort of social and emotional reality. So it's sort of on a bell curve. Again, it's not about having the right answer, but an answer that most people would sort of agree on. And difficulties with this are present in both psychosis and in autism. The last thing is cognitive regulation and reasoning. And that's the last component of social cognition. This is really a more frontal cortex, dorsolateral prefrontal cortex mediated activity. This includes things like being able to pass the false belief test. So when we start our year with medical students and our residents, we always invite in a 3-year-old and a 5-year-old to do this. So we take a box of cookies, we show them to the 3-year-old, we say, what's inside this? And the 3-year-old says, cookies. And then we show them taking the cookies out, we put rocks in, and we say, what's in there now? And the child will say, rocks. Okay, when your mom comes in the room, what is she going to think is in there? And the 3-year-old says, rocks. Why? Because there's rocks in there. The 5-year-old thinks it's hilarious and rolls around and laughs and thinks this is the great fun. And usually, you know, if they have a sibling with them, they particularly love this, because we replace the cookies with rocks, and we say, you know, what is Bobby going to think when he comes in? He's going to think there's cookies, but there's rocks in there. He thinks it's hilarious. So first order theory of mind is being able to anticipate or know what another person might be thinking. And second order theory of mind is when we can anticipate, well, what is somebody thinking about what somebody else is thinking? And a paradigm that you can use to rate second order theory of mind is something called Strange Stories by Francesca Hoppe. She developed these little cartoon vignettes about what somebody's thinking about what somebody else is thinking. So when we say, you know, we would, you know, maybe ask a child of 7, you know, what's going on here? When this person says, look, this banana is a phone. And the savvy 7-year-old will say, well, we say, well, is what this person says true? And she would say, no. And well, why does she say it? Oh, because that person is pretending to the other person. They want to play. A very concrete 7-year-old would say, yeah, that is a phone. Well, what makes you think that? Well, it's clearly a banana phone. So those are, again, awareness, meaning, and reasoning are 3 qualities of social cognition that can be disrupted in both autism and schizophrenia. There are some shared clinical features. And so here's our Venn diagram. In autism, you've got some, and in psychosis, you could have mild perceptual abnormalities, atypical behavior, motor disturbances, sensory overwhelm, communication difficulties, bizarre thinking, and social impairment. Trending towards psychosis would be outright hallucinations and a lot of delusional ideas about how the world works. In autism, you might have more of these nonverbal communication deficits and more of these repetitive behaviors. Here's another table that comes from a paper on entitled Autism Psychosis or Both: Unraveling Complex Patient Presentations. And again, it gives you very similar social emotional challenges, communication challenges, a little bit of the differences around unusual thought content, which I think can be present in both, but we would trend towards more delusions and more hallucinations in individuals with psychosis. And then you can see repetitive movements could be present in both psychosis and autism. I'm going to, and now I would like to blow your mind by making it even harder for us. When we consider some of the cluster A personality disorders that exist in the DSM-5, it gets particularly difficult. So we can think of schizotypal personality disorder, schizoid personality disorder being on a spectrum or being part of a Venn overlap with ASDs and schizophrenia spectrum disorders. Really quickly, schizoid personality disorder. This is the, I hate to use the word, and I don't mean it pejoratively, but this is the sort of loner personality disorder. So these people, people who have this disorder tend to be not desire close relationships, almost always choose solitary activities. This is the example of somebody with schizoid PD par excellence. It comes from a novel by Kazuo Ishiguro called The Remains of the Day. And in this film, Anthony Hopkins plays a butler who strictly adheres to routine. He's unable to enjoy the kindness of others and the warmth. He's not inspired to intervene when he sees his boss being played by Nazi sympathizers. So it's a really incredible film. I give you an example of precisely this as Emma Thompson tries to engage this actor, the character, and he rebuffs all of her, sort of indifferently rebuffs all of her kindness and warmth. Schizotypal personality disorder is a little bit closer to schizophrenia. This could involve having ideas of reference, magical thinking, some unusual perceptual disturbances or experiences, including bodily illusions, suspiciousness, paranoid ideation, and being excessively anxious. Now, this is a slide, I'm not going to read it, but I would invite you to read this later. But I just want to emphasize my version, and I hope our version ultimately of personality disorders, is not that somebody is the wrong kind of person or that this makes a person a bad person. But this is it's a way of speaking about people who have difficulties and externalizing this. I think we might better call these intrapsychic and interpersonal functioning disruptions, and that we do really well not to use any personality disorder as a pejorative, but instead as a way to describe someone in pain and how we might help them. So I really want to emphasize that because I think PDs have gotten a bad rap. All right, let's talk about the age of onset and some differences and some assessment tools that we could talk about. So first, most people develop schizophrenia later. So for men, it's usually, and this is natal gender or birth gender assigned men, 15 to 25. For women, that is 20 to 30. Approximately somewhere between 12 and a half and a third, and up to 33% of people develop symptoms before age 18. There's a 1.4 to 1 male to female ratio in the diagnosis. The childhood onset schizophrenia, true schizophrenia, is extremely rare. And internationally, the prevalence of schizophrenia is around 1 to 2%. And here's just a graph in one cohort of the age of onset for schizophrenia spectrum disorders. And you can see that skew: young men a little bit earlier, young women a little later. Autism, meanwhile, has a prevalence of pretty similar in developed countries to schizophrenia. The average age of diagnosis in youth under 10 is about age 3.5. It has a male to female ratio. It was thought to be 4 to 1, but that number is reducing as we recognize more and more that the qualities of autism in young women. One of the questions is, why would people, some people aren't diagnosed until, middle school, high school, even being, in transitional age youth. And what contributes to people getting diagnosed later, we think there may be some lack of external or overt symptoms. People may have quieter symptoms. They may have been treated for ADHD, social phobia, OCD, and their autism diagnosis missed. People of higher SES and of certain ethnicities, being, upper middle class to upper class, quote unquote, socioeconomic status, and being white in the US means you're more likely to be diagnosed with autism, and autism being diagnosed to other things if you're not. And you'll see that in places where they have a great autism diagnostic center, you'll see a lot of people diagnosed with autism. So it's an access to care issue. And there are probably also sex and gender differences. In terms of what is expected of girls societally, also there may be some brain differences. So there's a great paper on this, which I can share if people are interested. Some early autism presentations. So these are 2 young people that I saw in my training. So sent by his school for an evaluation of extreme tantrums, grunted responses with poor articulation, and a weird habit of snapping, a 5-year-old was referred to my clinic. When I went to greet him, he was lining up cars over and over and then knocking them over, clapping and repeating with no eye contact. And his mother was watching him adoringly. And it became crystal clear almost in those first 5 seconds, like, oh, I think this young man, and this is a young person who, by the way, was an immigrant, had looked different than most people in his school, and the family did not, they were English as second language speakers. And so I really feel like some of his language difficulties and communication difficulties were attributed to that, as opposed to, unfortunately, to autism. But he did get better. We got him great services and he did very well. A 4-year-old girl, meanwhile, she says hello while staring at the ground. And then she returned to this shape block toy in the waiting area, putting the wood blocks in over and over and then clapping. She then raced to the elevator, pressed the button over and over and over. Meanwhile, through all of this, she would eat the pills on her sweater. She would notice a new pill and then eat them. So that was just another presentation, and you can see how it gets some of those RN SIRS qualities. The gold standard assessments for the diagnosis of autism, there are 2. There's the Autism Diagnostic Observation Schedule, the ADOS. This can consist of 4 modules. They are based on language development, and you really need to you should probably do a full-scale IQ and a language assessment before administering this. That's why they're not readily administered by folks like us, because it really often is best as part of a package of neuropsych profiling. Then there's the Autism Diagnostic Interview, or the ADI revised, that's the R. And this is a standardized, semi-structured interview for parents and caregivers of individuals with suspected autism. And again, it's nice to have a connection within our programs to someone who does a lot of these. As a standalone, they tend not to be as effective. 2 tools that we can use, those of us mere mortals who do this work but may not have a lot of experience doing the ADI and ADOS, we can use the social reciprocity scale. This is a 63-item screening tool that gives people scores versus the population norms. This only works for people aged 29 months to 18, and it gives you these 5 subscales. So this could be useful. You have to purchase these. These are both proprietary, but this can be a useful scale for outlining qualities of autism spectrum disorder, particularly in individuals who you suspect have had autism for some time, or they've always met criteria, but they were misdiagnosed or just completely, or they weren't diagnosed with anything. Then you can use the social communications questionnaire, the SCQ, and this helps you do the thing that I'm just about to suggest, which is take a really good development timeline. So the best way that we can do this with simply a DSM-5 in hand and our clinical skills is really ask questions. How did a child feed? How did they sleep? What was their motor functioning like? What was their sensory experience from birth to present? What was their toilet training like? What was their social functioning like from birth to present? Did they have interest in friends, interest in others? What's their capacity been for sustaining conversations? What's their capacity for team activities and collaborating, playing with others? This is group projects in grade school as well as team sports. What's their capacity for sustaining relationship? Can they make a friend and then can they keep that friend? Or what are the difficulties in all of these domains? And then what is their capacity for tolerating groups of different sizes? Finding out about magical beliefs versus kind of grounded beliefs. Magical thinking is common in a 4-year-old, but if that persists until somebody's 8, 9, in their teens, that then it would be abnormal. I need to ask about academic functioning and teacher reports, including teacher reports on social life from even preschool on. And then finally, looking at videos and making your own assessment. This is where you might be able to see some of those things like neurological soft signs. You might see stereotypies. You might see poor eye contact in the individual who's at their first birthday makes no, seemingly makes no contact with their parents. You might see the absence or presence of a lot of friends and interactions with other friends. So watching videos from different developmental eras can be useful. And I found this really useful in young people I worked with who had schizophrenia, seeing a lot of these signs and recognizing in a couple of individuals comorbid autism and then onset of psychosis. So this is what this looks like. I might create a sheet where I have columns, or I might draw this however you wish, but I want to really isolate these different epochs: infancy, preschool age, school age, middle school, tween years, high school, and then emerging adult sort of years. And then I would ask about those things: sensory, social, academic, kind of worldview ideas, and then motor functioning at those different ages. And then particularly if they're seeing us, usually they're referred, folks are referred to us for psychotic symptoms. And so I want to know the age in which those symptoms of psychosis were present. And so what we might find in the person in, let's say we're looking at that 10% of people with autism spectrum disorders and then onset of positive symptoms or symptoms that are added to their sensory experience, I might see somebody with ASD qualities all the way up until age 16, and then the onset of symptoms. So create this developmental timeline for each patient in whom you suspect dual diagnosis. The cool thing is recovery-oriented coordinated specialty care works for people with autism, and it works for people with schizophrenia spectrum disorders. And I know we've been talking about this for a long time, so you know that these things help folks with early psychosis. It would also be helpful to individuals with ASD and new onset psychosis. When we think about treating somebody who has both ASD and schizophrenia, we really need to break down silos. So there may be some aspects of their care that need ongoing support through developmental disability or ASD services. That might include really good applied behavioral analysis, like sort of gold standard treatment for changing behavior, helping with pro-social behavior and helping with functional outcomes in individuals with autism. So somebody might need to continue that, and they might also benefit from some coordinated specialty care that we offer, including some cognitive behavioral therapy for psychosis. How do they, if they do have symptoms of psychosis, if they do have hallucinations, how do they develop a relationship to those hallucinations that works for them? And what you may end up finding is that the applied behavioral analysis, technicians and therapists, they need to get together with those of us who do CBTP and brainstorm, well, how do we help this person sort of functioning while they're at school? So a lot of this is going to be, collaborating. At the program director level, this is advocating for our patients and families so that they can get both services and not taking no for an answer from Medicaid, the people who give us our Medicaid dollars. If you want to learn more about autism, you might read Naoki Higashida's The Reason I Jump. This is about a father learning to listen to his son who is nonverbal, but listening to his body language to better understand his son. Temple Grandin's Thinking in Pictures is also a beautiful book. There's a novel, The Curious Dog, or Incident of the Dog of the Night by Mark Haddon, is a lot of fun. And this is about a young man previously would have met criteria for Asperger disorder. And then finally, this is a book that a few parents that I've worked with found really useful. It's A Parent's Guide to High Functioning Autism Spectrum Disorder. To learn more about schizophrenia and the lived experience, I offer these books: The Collected Schizophrenias by Esme Wei-Jun Wang. Michael Greenberg is a journalist whose daughter developed or had a psychotic episode, and he writes about it really eloquently in Hurry Down Sunshine. Ellen Sachs, she's a USC law professor and a psychiatry professor. writes about her own schizophrenia and her own experience of getting humanistic treatment versus very coercive treatment in The Center Cannot Hold. And then finally, Robert Kolker wrote Hidden Valley Road, which details a family where 6 of the 12 children developed schizophrenia. And so offers multiple perspectives. So this is what you learned from me. Hopefully you really learned it. DSM-5 criteria for schizophrenia is DHS-BENS. The criteria for autism spectrum disorder is RN-SIRS, or reciprocity difficulties, nonverbal communication difficulties, stereotypies, insistence on sameness, restricted fixated interest, and sensory disruptions. You learned there's historical, clinical, and neurobiological overlaps between the two. Eugene Bloiler was the first person to use the term autism, but he used it to actually in 1913 to talk about schizophrenia. And then there's this clinical feature overlap. So atypical behavior, motor disturbances, sensory overwhelm, communication difficulties, bizarre thinking, and social impairment are shared qualities. And then there's shared genes and heredity, gray matter reduction, risk of psychosis with ASD, neurological soft signs exist in both, and social cognition difficulties. And you can use this longitudinal approach to discovering when symptoms started and go really slowly from, from birth and even prenatal care all the way to the present. You can also use those two things, the SCQ, that's that social communication questionnaire, valid from age 4 to 40, and that helps you develop a timeline. And then there's that social reciprocity scale that you can use up to age 18. And now let's talk about Brian. So,
hi, everyone. I thank you so much, Craig, and that's really valuable information included in there. I also just want to bring up, I am aware of your meeting time. Yes?
Yes, actually, I'm glad you brought that up. We have you down for 15 more minutes.
Oh, okay.
Yeah, we actually, I don't know if everybody noticed that, and I should have mentioned that at the beginning, but we did extend this meeting to 12:30 here in Kentucky. So I have you down for 15 more minutes.
Okay, wonderful. Good, good, good. So that's actually perfect, because what this case study is about is as we're learning this information about autism and mental illness and how we identify what are the differences and the similarities, it's often super helpful to actually have a case of an individual to start thinking about what we just learned in this presentation and be able to apply it. And so what I have here, Brian is actually not anyone that I have worked with. Brian is a case study for this presentation. So what I'm going to do is I'm going to read a little bit about Brian, and then I'm going to demonstrate some of what Cragen has talked about this in gathering, wanting to gather that historical data and what's the biopsychosocial information that we're looking for, what kind of past therapy this individual may have had, accommodations, medical history, some of the sensory cognitive stuff, and then also, of course, the social aspect. So what we have here is Brian. He's a young man, aged 18 years old, who has been in a First Episode Psychosis program for 6 months with a diagnosis of autism, schizophrenia, and generalized anxiety disorder. Brian has specific interests in art, computer graphics, programming, chess, and his work at a consignment store. So as we look and gather this information, what we have found out is that he did have all 3 therapies when he was younger, and they did create an IEP for him at age 9. His family history includes both schizophrenia and autism. There was some isolation that he experienced because of bullying as a youth, and that as far as some of his cognitive challenges that he has currently is sustained attention. He has difficulties when the environment isn't controlled, and this carries over into all environments. So that is something to keep in mind. Is it just like what Cragen mentioned? Is it just at school? Is it just at home? Is it just in therapy? And then also problem solving and he's a poor historian in relation to time. When this is an opportunity also to be sure to, when you are doing the assessment, is to gather information, not just from the individual, but of course, asking permission, gathering information from the parents, other folks that have been involved in the individual's care. As far as language and processing challenges, he will often repeat certain messages. He will perseverate on statements, both towards himself and with other folks. Another piece that shows up is he's very eager to say yes to suggestions and therapy, ideas. And this is something to consider and be aware of, is that over eagerness to please. And also perhaps even that might mask some of the symptoms. We talked about diagnostic overshadowing earlier in the presentation. His sensitivities are odors and sounds, and then some of his repetitive behaviors are, he really will spend a lot of time organizing objects. And then as stress escalates, you might see some flapping of his hands. And that's one of his calming strategies. Next slide. So what I want to propose to the group is think about what might show up now for Brian. So pulling from what we know so far of Brian, what would be a sensory challenge he might have at school? This would be just if you all would offer up an idea. Lunch, yeah, great. That would actually be both sound and smell. What else might show up for him? Playground, oh, great. Yes. And then what would be, yes, sitting next to the window in class. Excellent. Can be very distracting. I would even gather thinking about, classrooms. There are different sounds in classrooms also. There might be overhead lighting that has a buzzing sound. There might be the, heater that goes on and off. And how close are you to that? Another class pet. Hadn't thought about a class pet. That's a great one. And loud classrooms. Yeah. Oh, yeah. So a lot of times the celebration for a classroom is about having a party and bringing in foods. So great ideas. The other thing that I was wondering is, and changing classes. As far as accommodations for him, what would be an accommodation you might see for sustaining attention or adapting to problem solving if he's having challenges with problem solving? Mm-hmm. Perhaps he has someone assisting him in a smaller classroom. Yep. Changing the location of where you sit in the class is a wonderful idea. An extra tutor, alternative activities. Alternative activities can be really powerful because, as we know, when someone is having these extra challenges, that it's more draining on your energy level. And so if we can maximize our energy in other ways throughout the day, so that if there is a particular activity that's very draining, so that the rest of the afternoon, an individual is an overload, that's an excellent strategy for an accommodation for school. Yes, and of course we all learn differently. Thanks, Craig. Next slide. So here's what I have for Brian. School challenges Brian with loud noises such as the bell ringing between classes, crowded hallways, adapting to different classrooms, and certain odors, for example, gym class and the lunchroom. His IEP for school allows him to transition prior to the bell ringing. He has concert level earplugs, the ones that lower decibels, that he wears in the hallway, and he sits in the same seat in every class to aid in his comfort level transitioning between classes. That way it feels familiar for him. He has chosen a certain light essential oil that helps him stay in tuned more centered to different odors that will periodically show up through the day, so it doesn't throw him off. He also has a smaller room for test taking, and he also uses that room anytime that he notices the differences within his body that his anxiety is elevating. So as you can see, all of you really actually touched on all of the accommodations that Brian has now had in school, and then some. Next slide. So this next step is really going to be about taking what Dr. Usher spoke to throughout this presentation. And what I would like is, as I read this, what details can you pick out that might suggest that Brian has, that Brian was diagnosed with autism at a young age and is developing psychosis. Okay. His challenges with language became stronger when he is experiencing a higher level of anxiety. Communication has become more difficult in the last year, and he feels a particular group of students that often wear black are analyzing him, and something bad is going to happen. Brian is having increased difficulty connecting with peers and coworkers. He started walking away when someone speaks with him, fearing he will say something unusual. Despite feeling unconnected, he is sensitive to the emotions of others around him, noticeably feeling sad when someone is sad or hurt, or quick to laugh when someone is happy. Would someone volunteer up what might be a suggestion of, or an aspect that might be developing psychosis or a symptom? Yep, delusion, feeling of doom from group of students, fear of speech, rapid mood dysregulation. Thank you. Absolutely. Now, what would be an example of autism?
The leaving in the middle of a conversation, that kind of avoidant behavior, and the anxiety.
Yes, and then I mentioned that overload, and so that can happen sometimes where an individual will shut down, and you might notice changes in their posture, behavior, that would be perhaps unexpected in a different interaction, or if their anxiety level is much lower. I will speak to anxiety. I've read some research that actually says about half of individuals with autism have some sort of diagnosis of anxiety. Okay. Great. Any other thoughts? All right. Next slide, Dr. Usher. So as we consider his behavior and experiences, as we're getting to know Brian, I would like again to challenge us when we read through this, what would be psychosis, autism, and anxiety? Brian's main present concern is he wants his consignment store job to be a success. He has been struggling lately and has had to go home early a couple days. He is very particular about the time the daily supply truck arrives, as a slight change in the schedule is distressing to him, since they will ask him to do something else when the truck isn't there, and he likes his regular routine. Staff recognize changes in his behavior, such as repetitive statements he makes about the truck, organizing and reorganizing the glassware by size and color, and pacing. Brian also wants to feel more comfortable at school and make a few new friends. His family wants to support Brian in both school and work to help him feel less anxious overall and safe in these environments. So as I read through this, what might be an area that you would prioritize for his goals? Thank you. A suggestion is to adjust his work schedule to be more routine, complement this with schedule at school to allow for more time. Wonderful. Anything else? Vote for his family. When I working with yes, maybe practicing role-playing communication or work strategies in the home. Wonderful, thank you. Lots of opportunity for psychoeducation. So on the next slide, what I've done is I've taken what we know about Brian so far and what is showing up for him as his priorities. Of course, when we look at goals, we always want to prioritize what is Brian's priority and what are his parents' priority. So what I've done here is just a reference for you all is I've taken statements that Brian's made and his parents, and I've written out what a goal might look like. So for Brian stating, I want to make new friends in my classes, a goal could be that Brian will develop and utilize a reference book for communicating at school and work, targeting expressions for opening and maintaining conversations. When Brian says that he doesn't want to feel so worried about the truck at work all the time, we can have Brian, we can work on this goal, Brian to engage in an unfamiliar task when asked at work, utilizing his preferred calming strategy of deep breathing and pressing his palms together prior to initiating the task with a reward of a short break of 5 minutes playing computer chess. So we take an interest of his, there's a reward, and there's incorporating some of the stress reduction strategies you may have been utilizing in your work. And now lastly, for his parents, I want to help him, but he gets so irritable these days, it's hard. Well, we can work with the family around psychoeducation for routine, both prior to and following school and work. We can work with implementing family guidelines to promote positive interactions and Brian's independence. Psychoeducation here is also helpful for the parents to help them identify what's autism and what is emerging psychosis. And why are things that they felt were going smoothly, why have those things changed? And so we also help the families make accommodations. We also help the families make accommodations from a sensory perspective, changing the lighting, changing the sounds, because remember, it's about keeping in mind when our bodies aren't feeling in homeostasis, it can be exhausting. And so what we want to do to help Brian the best that we can is we want to help him be able to reach his goals, but also make accommodation adaptations around it to help him preserve his energy as much as possible, so that at the end of the day, he's not wiped, exhausted, and overloaded. Okay, next slide. So here are just, Cragen has more specific assessment suggestions, but really what this is I wanted to put together a review of some key pieces to keep in mind as a summary of what we're doing when we're working with our youth. So again, we're getting as many records as we can ahead of time. We want to have a comprehensive assessment that's going to include the biopsychosocial components, history, and we integrate all of that. We're going to use not just interview, but like getting to know all the people that care about Brian. Also, Brian, be sure to, but also remember asking for consent. We also utilize observation, like Cragen mentioned, videos. It's a neat idea of how to do that. And then we look for strengths, changes, and then, of course, as we're doing this, realize this is a new environment. Some of the accommodations we might have to make are within the therapy environment as well. So we're always looking for any signs of distress. And we change what we're doing if they're becoming evident. Next slide. Some general treatment suggestions would be very similar to what we already do. We're going to be, reflective listening. So we're all, we learn how to be very good listeners and we reflect back. That helps through problem solving. What are the goals? What is important to Brian? We want to also keep in mind that it might take some extra time. Processing might be a little bit slower or different, might have a different beat, might not be, it's not necessarily bad, it's just different. So maybe even frequency of therapy is changed or the duration of therapy broken down into smaller chunks. We're keeping in mind always the accommodations our language, try not to get caught up in, vague ideas. Be as straightforward as possible. Don't be afraid to try something new in therapy. Maybe the first part of therapy, you're on the ground and you're drawing pictures together. Maybe you notice that what's really helpful is moving prior to anything that has to do with talking, and of course, becoming more and more well-versed in the social communication aspects that are challenging for autism is really helpful with that. So we learn how to express ourselves in other ways. That's still communication. And then visual supports, multimedia is always helpful with therapy, no matter what. And if there's any type of adaptive language supports, again, that could be visual, it could be written through storytelling, poetry. And then, as usual, we work with our youth, and then we make sure in our families, and we're collaborative. Next slide. So, in summary, thank you all. So therapy for our youth with autism spectrum disorders in first episode programming is not much different overall. The principles are the same. Modify your approach as needed and consider the significant benefits in helping youth reach their goals with creativity, flexibility, and informed collaboration. What's happening here is we all, because of the work we do, we all know adaptability, and we all know collaboration and honoring voice and seeing people, listening, all of these, they all apply here. And it's about being flexible and making some slight adjustments, and we'll continue to do the good work that we're doing. Thanks.